We hear that there's some kind of sports event going on in the city. No, but apparently what it's done is both closed off streets, so it's not easy to get here since Fenway's not too far away, and also apparently some people wanted to watch it. So we have a smaller audience than we normally would have, and that's unfortunate because the topic that we're going to be talking about is a topic of enormous interest in healthcare, and that is single payer. Before going into that, I just want to take a minute to remind people that this evening is part of a series of educational sessions that take place on Wednesday evening from 6 to 8 that are part of the Open Classroom series, and that is a series that is held every year by the School of Public Policy and Urban Affairs, focusing on a different important area of policy. This semester we're focusing on health policy, and the course is being overseen by Professor Timothy Hoff from the DeMoore McKim School of Business, and by Professor and Associate Dean Wendy Parmet from the law school. I'm John Auerbach from the Beauvais School of Health Sciences. Please come during each week. We have a different topic each week, and I'll tell you in just a little while what's scheduled for next week. So this evening we're incredibly fortunate because we're joined by two leaders of Vermont who are playing a critical role in terms of the healthcare reform initiative in Vermont, and that reform is ultimately going to lead to Vermont becoming the first state in the country that adopts a single-payer system. And that, obviously, for many people in the country was something that they hoped would occur with the passage of the Affordable Care Act, and didn't. And for some folks, they thought, well, maybe that won't happen now in America. And so seeing the work that Commissioner Chen and Dr. Hester have done over the years to work on the policy components, the availability of clinical care, the focus on quality and cost, and the specific step-by-step movements that will allow Vermont to achieve that is quite remarkable. So let me move right now into the introduction of our speakers. As I said, we're honored to have with us these two speakers, and we're particularly honored to have with us the Commissioner of Public Health for the state of Vermont, Dr. Harry Chen. I'll tell you a little bit about his history. Dr. Chen worked as an emergency room physician in Vermont for over 20 years and actually served as a medical director of the Rutland Regional Medical Center. He has somewhat of an unusual history in that while being a practitioner, he also was a state legislator. So Dr. Chen was a member of the Vermont House of Representatives and was actually vice chair of the Healthcare Committee during his final term, and that was a committee that was paying particular attention to healthcare reform. As the Commissioner of Public Health, which a position he's held since 2011, he oversees a department that ensures that he is involved with every health issue that arises in Vermont, whether it is mosquito-borne illness, Triple E and West Nile virus, as it has been during the last few months, or it's emergency preparedness, whether it's substance abuse or infant mortality, whether it's focusing on infectious disease or chronic disease. Dr. Chen has been in the lead of those issues in his state. He is a national leader that has testified before Congress on a variety of issues, and he's also a leader in the Association of State and Territorial Health Officers. I believe now, I think what I'll do is introduce Dr. Chen. He's going to speak first, and then I'll introduce our next speaker, who is Dr. Jim Hester. So please join me now in welcoming Commissioner Harry Chen.
So thanks, John. So I want to, it's really delightful to be here despite the competition. And I was on a phone call with my with my office. And I'm driving down here in Boston to give a lecture. Everybody else is driving down here from Vermont to watch the game. But I'll have to check how it's going. I actually started my actual medical career as a doctor here in Boston, so this is an warm place in my heart here. And that was at Boston City Hospital in 1979, and they still had the tunnels. And when you could walk into the ER, I'm an emergency physician, so I never forget the first time I walked into the ER when I was interviewing that all the, so let's say, inebriated residents they're all just lined up by the sink. And then we're washing their hair, and getting out the bugs and cleaning off, and getting ready to be sewn up, after because they had fallen down. So it was quite an experience. It was I tell people it was really one of the best years of my life, and clearly one of the worst years of my life too. I learned so much medicine, it was just incredible. So anyway, it's been a long time since that. So today I want to spend some time, and I'm going to try my best not to be too kind of healthcare wonkish, so people can actually understand what I'm saying. Talk about the road to single payer in Vermont. I want to talk briefly about the case for healthcare reform, how in Vermont we're leveraging the Affordable Care Act to transform healthcare, the Vermont context. So it's important to really know, why, how can we do this in Vermont? What's different about Vermont? A couple different important pieces of legislation, Act 128, in which a framework was laid out for our single payer system by a Harvard professor in economics, Dr. Chen. And then finally, the embodiment of the actual reform, Act 48. And then I never miss an opportunity to put a plug in for population health and public health, because in the end, that's what's going to lower our costs, get us healthier, and make us a more productive, happier, and healthier society. So this is actually at my national meeting this year. Dr. Blumenauer from the Commonwealth Fund spoke, and I actually borrowed and attributed some of his slides. But the sad fact is that Americans live shorter lives and are in poorer health at virtually any age than our compatriots in the world. Poor outcomes, really, you can't explain it on the basis of poverty, because even comparing white, educated, wealthy Americans, we don't do as well health-wise as our compatriots in the developed world. So that's the challenge. Fortunately for those of us here in Massachusetts and Vermont, there are actually two healthcare Americas where in terms of performance, there's high-performing areas and low-performing areas. Vermont and Massachusetts are obviously in the highest performing areas. And as you can see, there's in the southern U.S., there's a deep pocket of where the disparities are greatest and the health is least positive. So we have a broken system. And briefly, I'm not going to talk a lot about it, but we're spending billions in unnecessary wasteful spending. We have overuse that puts patients at risk, drains our resources, and makes us less, in the end, accessible and effective for all. We have, despite the greatest technology and advances we have in the world in terms of medicine, we have thousands of patients that die each year for medical errors. And we still have a significant portion of Americans that are not covered in terms of insurance. This is what I call a value equation, the kind of the crudest value equation in terms of health care, and that is how long you live, which is pretty much commonly equated with the kind of care and health you have in your population and how much it costs. And on the bottom is the graph of how much spending, and on the up and down is the life expectancy. And so you really want to be at the top left-hand corner. You can see America is all the way up here, all the way on the right. It costs the most, and it has kind of mediocre longevity at best. So ideally, we want to move that, and that's what our goal is in terms of reforming health care and health. Another way to view this is potential years of life lost because of diabetes, and the median of the developed countries is in the middle, and The U.S. is all the way on the left, and again, a higher number or more years of life lost, and therefore least healthy. I'm not gonna, this is basically the spending. You can see that we're, again, in America, per person we spend roughly twice as much as our nearest counterpart. So because of the spending issue, really, we can't solve this problem by just putting more money in. So cost is really, cost control is job number one. We can't cover more people, we can't have healthier people by just pouring more money into it. And where are we going to get this money? Where are we going to get the efficiencies? And there's a lot of waste in terms of failures in delivery, failures in coordination, overtreatment, administrative complexity, fraud and abuse. And it's in a $3 trillion healthcare industry, probably 20% of that is estimated to be waste. So that's about $750 billion a year. So we need to have fundamental delivery system reform to make it easier to do the right thing. Health system performance is really determined by the interaction between microsystems and macrosystems, and I'll explain briefly what I mean by that. A microsystem is what happens between a doctor and a patient. That's healthcare right on the ground, in that operating room, in that doctor's office, in the ICU, or in the operating room. So it's the people, processes, and practices that interact directly with the patient. The macrosystems are the kind of overriding things that kind of control what the microsystems do. Hospitals, accrediting boards, government regulators, insurance plans, and things of that sort. That's what we'll call the kind of the blunt end. We really actually just are starting to see the effects of a really significant piece of legislation, and that's the Affordable Care Act. I think a lot of people wish it would have gone through, but in total, I think it really did make a very significant change in the way we approach healthcare and insurance in this country. Maybe less so in Massachusetts and Vermont, but I think it's really key that the rest of the country is really coming up to what previously were our standards. So some of the tools in the toolbox in terms of the macro system for the Affordable Care Act is value-based purchasing, medical homes, meaningful use for the use of information technology, bundled payments, reduced payments for avoidable complications, and accountable care organizations. So these are all things that are part of the Act itself in terms of trying to change our delivery system in healthcare. I'm going to briefly go over the Affordable Care Act because, again, I think it really is a significant piece of legislation. And it's four major themes, which is coverage, benefits, affordability, and consumer protection. In terms of expanding coverage, like Massachusetts did back in the 2000s, there is an individual mandate. And it's pretty clear from the insurance model, you can't get everybody in, meaning if you can't get healthy people in, then the actual cost of the insurance model won't work. And so that's why the individual mandate is so essential, and that's really why the insurance company went wrong in terms of changing the way they their consumer practices. The Medicaid expansion for single, non-disabled, non-elderly, non-pregnant adults. These are populations actually that are very new for the states that are expanding the Medicaid, but it's actually old news for many other states that have done this all along. The exchanges, which are the virtual marketplaces, which have been in place in Massachusetts for a long time, but as everyone knows, have been rolled out as part of the Affordable Care Act. And then the extending dependent coverage, something really, really simple to do, something that probably a lot of people in this room are taking advantage of. It makes a huge difference because dependents don't cost much money because you're healthy, and getting them in, again, puts more people that are healthier into the insurance system. Comprehensive benefits, important, that they're not, it's not just a high deductible plan, that as part of the Affordable Care Act, there's no cost preventive services. This was a tremendous change, meaning we want to ensure that Americans get preventive services like mammography, like colonoscopy, like screening for substance abuse, without any cost to them. I mean, that's a really, so even if you have a high deductible, you're still going to be able to go in and get your preventive service because it really acknowledges the fact that prevention pays. And then finally, the Public Prevention and Public Health Fund, which was initially funded at $18.7 billion, acknowledging that we don't spend enough for prevention, and that we need to invest to, in the end, lower our costs, improve the health of Americans. And then finally, affordable coverage in terms of subsidies, out-of-pocket limits, which are important, and the consumer protections. In terms of no annual or lifetime limits, guarantee issue, meaning you can't be denied because of pre-existing conditions, and again, no discrimination based on gender. And these are all things that in Vermont and Massachusetts have been there all along, but just the mere fact that they've extended them to the rest of the country really is a very significant event. So Vermont, traditionally, over the past 4 years, has been ranked the healthiest state in the nation. Interestingly enough, back in 1990, when Vermont started to try its efforts in terms of health reform, it was actually ranked number 20. So in that intervening time, with attention to health and to healthcare, it's actually improved from number 20 to number 1. And it clearly, in terms of health, takes more than just healthcare to really to get a healthy population, and I'll talk more about that shortly. So, you know, what is it? Vermont's different, and the reason it's different is because it's really small. It's got 625,000 people. It has 14 hospitals. Most of the majority of them are really tiny hospitals, meaning critical access hospitals with less than 25 beds. And one thing that's significant also is that each hospital is kind of geographically located in a distinct area. So generally, people don't go they don't go all over the place to different hospitals. They certainly may go to their community hospital, and that's where they'll get most of their care. And then they also may go to one of the tertiary care centers. So there's a natural geographic community that's defined by a hospital, which helps when you're trying to control whether it be healthcare costs, whether you're trying to improve health in a certain area. There are only 3 insurers, only 2 in the small group market and non-group market, and the hospital budgets are really overseen in a very regulated fashion. And in 2011, there was a transition from a Republican governor to a Democratic governor, and in addition, there was a House and Senate that were all 2/3 majority, a veto-proof majority in terms of a Democratic leaning House and Senate. And I think that becomes important about how it all changed. Again, a couple other things I mentioned is that there's 8 FQHCs, federally qualified health centers, which are kind of community health centers or rural health centers that were set up to provide care in medically needy areas, and they have enhanced reimbursement, but they also have a much more comprehensive care network surrounding them to take care of their patients. And then finally, I think Dr. Hester will talk briefly about the blueprint, but probably the majority of Vermonters are taken care of in primary care practices that are NCQA certified, meaning they're advanced practice medical homes. That they have a very a robust system of whether it be information technology or systems within the actual practice that allow and enable them and allow them and promote them to do better care. But just the same, just like in America, the healthcare system really wasn't working for Vermont. It doubled in 10 years in terms of the healthcare costs from $2.5 to $5 billion. And in Vermont, 20 cents out of every dollar, roughly, that's spent in Vermont, that moves in Vermont, is spent on healthcare. Actually, that's more than what happens in America. Doesn't work for the Vermont families because in the time that you're doubling the healthcare spending, the wages were stagnant. So the healthcare spending could not and did not keep up with the actual increase in spending in the state itself, or certainly with wages. And despite the fact that Vermont has a very low uninsured rate, still there are roughly a third of Vermonters before we embarked on this reform that were either uninsured or underinsured, meaning they had high deductible plans and ultimately couldn't get the care they needed early on in a preventive fashion. And it doesn't work for Vermont doctors and hospitals. I'll never forget in one of our in testimony from some of the primary care doctors in Vermont, their response to the changing healthcare environment was they just have to move faster. So their response to lowering reimbursements, they had to see more patients, spend less time with patients, and move, basically move faster and not get home until later in the day. So it didn't work for them. For hospitals, they constantly had the problem with narrow margins, not being able to keep track of how many patients they had, and not be able to keep track of the dollars enough to be able to make it go financially. So you can see from this graph that this between 2000 and 2009, the average growth rate for healthcare spending was 8.3%. That was the time when our country was in the recession, and as you know, you couldn't match that growth rate in terms of wages. Again, the expenditures as a share of gross state product, Vermont's 18.5% in 2009. It's even over 19 now, even higher than the United States. So in response to that, Vermont has embarked on a very ambitious effort to reform its healthcare, and these are the goals. And these are pretty standard goals, with the addition of one, which is reduce healthcare costs and cost growth, assure Vermonters have access to high quality care, improve the health of Vermonters. And the one that we actually, that's kind of different, is assure greater fairness and equity about how we pay for healthcare. And this is where the single payer piece comes in. We have a long history of initiatives to improve coverage, to improve quality, and to control costs. Starting in the 1990s, in terms of covering children and pregnant women in Medicaid, and we had a program of essentially universal coverage for kids. And we had finally one of the earlier states to expand Medicaid, so it covered actually non-pregnant women, non-kids, and non-disabled back in the 1990s. We had multiple attempts at actually trying to do grander scale reform, but that just didn't work through the 1990s. Back in the 2000s, we worked on prescription drug initiatives in terms of promoting generics and bulk purchasing and drug lists in Medicaid, and then finally started to focus a little bit more on the populations that cost the most money to make sure that they got the best care. So if you divide up healthcare and you look at where the money goes, 75% of the spending in healthcare goes to 25% of the people. These are the people with multiple chronic diseases, with diabetes, with high blood pressure, with heart disease. And so it's really important to focus your efforts to ensure that they get coordinated, integrated, and comprehensive care. And that's what we try to do with care coordination. That's essentially what we're trying to do with the Blueprint for Health. Between 2004 to the present, we had a renewed push for a single payer system. And actually, in 2005, we actually passed a single payer healthcare bill. It was a less ambitious one because it actually only was single payer healthcare for primary care, because primary care doesn't cost that much. But that bill was actually vetoed by the governor. And actually, that governor several people actually ran against the governor who was, who was there when I was there, and each time they actually ran on single payer health care and lost. So, but that changed, and that changed in 2011 when there was the change to a Democratic governor who actually ran on single payer health care and won based on that. So things changed politically considerably in 2011, and in preparation for that, Act 128 was passed, which was to design and implement 3 healthcare reform options, including a single-payer healthcare system. This was piggybacked on the Affordable Care Act, so even though the Affordable Care Act didn't go far enough, it was really important to help us in a political sense and ultimately, we believe in a financial sense, to propel us into our single-payer healthcare system. So, as part of Act 128, we hired Dr. William Shao of Harvard, a healthcare economist, who worked with Dr. Gruber from MIT and another economist, and he had a team of 20 and some local Vermont experts also to design a healthcare system for Vermont. Dr. Shao actually designed was instrumental and helped design the healthcare system in Taiwan, which is a single-payer healthcare system. And he used his experience there to examine the Vermont system and help us design our system. The goals are pretty straightforward: universal coverage. Every resident will be covered with a standard benefit package and have access to care. We can control the healthcare cost escalation, and establish a strong, robust, community-based preventive and primary care system, integrated healthcare delivery system. He had 3 options that he was provided to us, including a government-run single-payer system, the kind of British system where you have everything more or less run by the government. Another one was a public option, like was proposed in the Affordable Care Act, which is essentially a public insurance company in the traditional way. And then the third option, which was a kind of a blend of a public-private single-payer system, which you had a essential benefit package, an independent board, and I'll get to that, and finally a third party that may very well be an insurance company that actually just manages the provider relations, just pays the bills, and may actually collect some of the money. So for clarity, I want to define what a single-payer system is. It's basically merely a system that provides insurance to every Vermont resident with a common benefit package, channels all the payments to providers through a single pipe with uniform payment rates, common ways of getting those payments, and deciding what people get paid. So the parameters that Dr. Shao had to take into consideration, which was to lock in federal funds, because we really couldn't afford not to take advantage of the federal funds in the Affordable Care Act, with no overall increase in health spending, no overall increase in spending for employers or workers, no overall reduction in income for physicians, hospitals, and other providers, and the payment method change in terms of change the way we pay to help improve care and establish an integrated delivery system. And important politically is that there was no change for Medicare beneficiaries. Because Medicare is a nationwide program, it was really essentially harder, if not impossible, to actually try to figure out how to include that into the system at this time. That doesn't mean we're not going to try it now at a later date. Dr. Shao estimated that there would be savings related to the reform, depending on the option, remembering that option number 3 is the public-private, and those different graphs indicate what he estimated in terms of his modeling to be savings related to that. Important in any system of a single payer is that you use your savings to improve your care, and that is covering more of the uninsured, improving the benefit package for every Vermonter, maybe providing some vision and dental coverage, and then investing in your infrastructure in terms of hospitals, community hospitals, and primary care workforce. So the recommendations from Dr. Shao were option number 3, as a public-private single-payer system, again, because it was most likely to be acceptable to the stakeholders, produce the most savings, and rely on the market when possible, and minimize political interference and it would be transparent and accountable. The desired effects were controlling healthcare cost escalation, that every Vermont would be covered based on the fact that they were Vermonters. It would actually increase employment, even though healthcare would actually be decoupled from employment, and we would create jobs, have a higher economic output, and enjoy better health. So as a result of what Dr. Shao did in his report, and the new legislature and the new governor, it passed Act 48. And Act 48 is really the bill that sets us on the path to a single-payer healthcare system. And that was passed in 2011. It established this regulatory board called the Green Mountain Care Board that was really primarily charged with cost containment, with payment reform, with workforce development, and really oversight over virtually all aspects of health policy. Important in this scheme is that this is a regulatory body which is independent of the government. So for instance, I'm a political appointee, and I would be here tomorrow, or I could be here, or I could be gone tomorrow. The Green Mountain Care Board is like a public service board model, which is actually they're appointed, but they can't be removed. So that was a decision to be made to try to remove regulation of healthcare from the political process, because at least in my experience, politicians always say yes. They always want to say yes, and they never fund things they say yes to. So there's a challenge. So you had to take it one step removed from the actual political process. The Health Benefit Exchange was established and is actually now up and running as part of the Affordable Care Act. Again, allowing Vermonters to get tax credits for their coverage and detailed planning for the actual single-payer system when we could get a waiver from the Affordable Care Act. So why single-payer? Well, again, it'll save the most money. It will be the simplest for patients, providers, and employers. There'll be administrative savings. There'll be efficiency in the healthcare system. There'll be simplicity, security. One of the things that was really important from our perspective and the government's perspective is that we would decouple health insurance and coverage from employment. So time and time again, we ran into stories of people when they lost their job, they lost their insurance. No longer would that be present, but they would really be covered based on the fact that they were providers. So the timeline itself, that was the first timeline that was actually part of the bill, but this is the simplified timeline that in 2012 that with Green Mountain Care would be working to control the cost, because again, cost control is job number one. No matter what we do or how you fund a healthcare system, if your costs are escalating in the way that they were in Vermont, it was unsustainable, and it didn't matter who funded it, who paid for it, it wouldn't work. So it's important to design a simpler system of coverage and financing. In 2014, operate a health benefit exchange for non-group and small group and public programs, and really to get everybody covered. And then finally in 2017, to ask for a waiver from the Affordable Care Act to allow us to establish our own single-payer system using public financing. Part of the bill was to go throughout Vermont and hear what people had to say about what principles and what ways they would like us to finance the system. The other thing we did was go throughout Vermont and listen to Vermonters in terms of what they felt were important for benefits. What kind of coverage would they want? And clearly one of the things that came up time and time again were dental benefits. And one of the things that the Affordable Care Act does, it didn't give dental benefits to everybody, but actually gave pediatric preventive dental benefits. So it's a start, an important start in terms of the money it can save down the road in terms of taking care of kids' teeth. So the Green Mountain Care Board, again, is charged with the 5-member board, regulation of hospital budgets, insurer rates, capital expenditures. They're charged with innovation, starting our innovation in terms of payment reform and changes to the state budgeting and processes to really try to achieve a unified healthcare budget in Vermont. Because one of the challenges about the way healthcare was financed is there was never a budget. It was basically, you went in, you got healthcare, you spent more, you got more healthcare, you spent more, you got more healthcare. And again, that was one of the challenges of the way the current system of both financing and providing care. By creating this budget is theoretically the way that we would be able to control those costs. And key to controlling costs is payment reform. Our current way of paying for care is the more care you provide, the more money that it costs the system. It seems to be simple and straightforward, but the problem is there's no financial incentive necessarily to save money. There's no financial incentive actually to provide high quality care. So there's very little opportunity for value, and there's way more opportunity in terms of spending more and actually having less value related to more care and more spending. So if you actually do the studies, more care is not better care. And actually in many studies in terms of Medicare that they've done out of Dartmouth, they've found that places that spend more actually have less optimal outcomes than places that might spend less. So I think that's something that at some point that we're trying to get away from fee-for-service. We want to build on our preeminent delivery system reform, those blueprint for health practices, the advanced primary care model. We want to include all payers, and we want to incorporate measures, performance measures for cost, for quality, and patient experience. All these things are important in terms of defining what the value equation is for healthcare. So these are some examples of payment reform. Instead of going to the doctor, having a procedure, what you might do is bundle your payments, meaning you pay a certain amount to have your hip done. You're not going to pay for this for the surgeon, this for each day in the hospital, this for the box of tissues, this for the medicines, this for the anesthesiologist. You pay one big amount for all of it, and what that does is really changes the way that people think about a procedure, think about a healthcare encounter, to work together, to be more mindful of coordinating care, to be more mindful of providing good care, and less mindful of just keep producing more care. So shared savings is another way of payment reform, meaning if you as a group or you as a hospital can actually save money, some of that savings goes to you and some of that savings goes to whoever's paying for it. And then finally, global payment. One of the things that I've noticed in Vermont is that the hospitals, because of all the regulations, are having a challenging time, as I said, making things work. And the reason they have a hard time is because their world financially is what happens on every month. So month to month, whether they have more beds filled, more hip surgeries, more lab tests, more MRIs, totally determines their outlook on what's happening financially. And so one of the things we'd like to do eventually is to do something called the global budget, which is take last year's budget, divide it by 12 roughly, put a little growth rate on it, and give them 1/12 each month. And imagine how different the world would be in a hospital if that occurred. You would no longer be looking at each of those little numbers about MRIs or surgeries or whatever. You'd be paying more attention to, are you providing the best care? Are you providing the best coordinated care? Are you providing the most efficient care? So it really just kind of changes your focus in terms of healthcare, and that's really what we're trying to achieve when we're trying to reform the payment system. Part of the payment reforms is really being incorporated into a SIM grant, which is a state's innovation model, using things such as shared savings, as I mentioned, bundled payments, and then pay for performance. The pay for performance is an example of that is if you're a doctor and there are 5 things that all doctors agree upon that are good things important to do for a diabetic. If you do all 5 of those things, then you actually get an enhanced payment. Kind of very simple and straightforward, and using metrics that everybody can agree to. So from our perspective, there's reason to hope if we can actually reduce cost growth rather than reduce spending. And I think it was important that when we talk about controlling costs. Nobody really realistically is talking about cutting costs, cutting the amount of care that people receive. I think what optimistically we could hope for is to modulate the growth to the point that it's more consistent with what's happening with the economy, with our economy, and with our ability to spend. And even that will achieve significant savings, purely based on the fact that we spend so much money on healthcare. So briefly, Vermont, like many other states, has set up an exchange, and actually different from many states. We've actually rolled in all of our Medicaid programs into the exchange in terms of eligibility applying, and we've actually not allowed any purchasing outside of the exchange. And the reason for that is because we wanted the healthiest group or the largest group within the exchange. And in addition, we want to use the exchange as a kind of our springboard technologically for a single payer system down the road. So our exchange is up and running. It's not without its glitches, as in many states, although obviously Massachusetts has the advantage of having a long history with an exchange. But we're certainly seeing the light of day in terms of improving efficiency. So I think a lot of people, a lot of the die-hard single-payer people were kind of disappointed that we were actually doing the exchange, because they said, well, why even bother with the exchange? Let's just go ahead and do it. And it really was financially important to do the exchange, because as part of the Affordable Care Act, there are subsidies for low-income Vermonters, middle-income Vermonters, up to a family of four, $90,000. So that's not really a low-income person per se. And those subsidies were key both to the affordability of the Affordable Care Act, and that actually will be key to our process of asking a waiver of the federal government. And I'll talk briefly about that. And we also used the over $100 million that the feds gave us to design our exchange, again, to design this IT infrastructure, both for our future single-payer system and also in and of itself our potential way for us to do claims processing in the future. So when you ask when you ask the federal government for a waiver, what you're really asking them is you want the feds to say it's okay for Vermont to do something different. So we have a rich history of waivers in Vermont, and I'm going to give an example of a waiver, and that's a waiver in Medicaid. And so what we said to the federal government in this Medicaid waiver was that it would be budget neutral. So CMS and the federal government, you're not going to pay any more money than you would have paid. As a matter of fact, you're going to pay less money. So we're going to guarantee that, because we're going to guarantee it, because if you won't pay any more, if we need to use more, it's all going to come out of state dollars. But you're going to allow us to do it in a different way. You're going to give us the same amount of money that you would have expected, but you're going to give us flexibility within that money. And that's what we did with Medicaid. We were able to use expenditures, to plot a growth, to cap that growth, and then to say if we save money within that, we want to be able to spend that money on things that would reduce the rate of uninsured, to increase the quality of care accessible to Medicaid beneficiaries and the uninsured, to actually use it for public health. Things like immunization, like fluoride, and preventing child abuse, and to encourage partnerships between the public and private sector, both to improve care, improve delivery, and improve access. And this is really what it looks like. The blue line is the best way to say it. Up at the very top is the cap, meaning we're not going to spend any more than that. We guarantee it. And the thing about Medicaid in the past is the more you spend, because it's a partnership between federal and state, the more everyone spent. And you kept spending and spending and spending. And there's really no limit to it in terms of the more care, the more people in the hospital, the more procedures, the more it got spent. So we said, we're going to limit our spending. We're going to figure out, we're going to agree together on what a normal kind of spending rate should be, and then any savings in that we're going to use for this other stuff that I talked about. the stuff that would, the vaccinations, the public health things that would actually improve the health of Vermonters. So we're going to actually, our plan is to do the same thing with the Affordable Care Act. So in 2017, we're going to say we can do it better. We think we can do it better. We can do it better for cheaper. And we just need your permission to do so. And that's what a waiver would do. And we would have liked to have done it sooner, but to have done it sooner would actually require an act of Congress. And knowing what we know about Congress, there's a cold day in a very hot place. So our goal is to go for that waiver in 2017, and to ensure that at that point healthcare is a right for every Vermonter, and every Vermonter coverage is based on their residency, that the healthcare growth is sustainable, that providers are paid fairly, that everybody pays their fair share, and that Vermont is the best place to do business, to practice medicine, and continues to be the healthiest place to live. So now I want to just briefly talk about public health, just because I'm a converted, I tell people that I'm a reformed politician and a converted clinician, meaning I used to be an emergency doc and now I've drunk the juice of public health. So it's really important for us to understand that we have to leverage the measly $250 per person we spend on public health to lower the cost of that $8,000 we spend per person on healthcare. And that's, if you're going to draw this to scale, it would be 32 times, that healthcare would be 32 times the public health. And why do I say this? Because if you look at, this is from a New England Journal of Medicine article, what is it that determines us to be healthy? What is it that determines how long we live? And it's not, you can see that healthcare is 10% of that. It's not healthcare per se, it's what we put in our mouth. It's if we puff on that cigarette, it's whether we take that walk at lunch, it's whether we drink too much or use drugs, it's whether we are overweight a little bit, so it's our behavior. And so we really have to start, that's one of the ways we're going to get people healthier. Certainly genetics, social circumstances are important, and a safe environment. But healthcare is important, but it's by far and away not the most significant. In the past, in the decade, the 20th century, it was estimated that we gained 30 years of longevity. How many of those do you think were from advances in healthcare? Take a guess. Of those 30 years in the 20th century, 5. 25 of them were related to things like clean water, clean indoor air, realizing tobacco control, vaccination, very simple things, clean, safe food, all those things that are safe food and safe water, all those things that we kind of take for granted, but that aren't healthcare per se. So if we're going to improve health, we have to work on it. This is the Thomas Friedman's pyramid about how you impact health and improve health. You have to do it at all these different levels. So let's just use, and at the bottom of the kind of very basic socioeconomic factors, above that are the environmental factors, at the very top of those things that take a lot of effort, the New Year's resolutions, I call it. So let's just say, take smoking as an example on this pyramid. When you say, oh, I gotta quit, I'm gonna New Year's resolution, I'm gonna quit smoking. That's at the very top. It takes a lot of effort. It probably has the smallest amount of impact. Down the line, if your doctor asks you and says, here are some nicotine replacement things. Here's a program of counseling you can use. That's probably a little more effective in terms of getting you to stop smoking. But really what does it are the environmental things. The clean indoor air laws, the fact that Northeastern is a tobacco-free campus. Those are huge things. I mean, many of us in this room remember when you used to be able to light up in an airplane. You had a smoking section in the back of the airplane. That's changed. That's the cultural change that we need to do. The environmental change that we need to accomplish better health for things, those behavior things I talked about, that are really the most significant effectors of our health and our longevity. So public health spending, more spending can certainly reduce infant mortality, reduce heart disease, diabetes, and cancer. So this, briefly, this is a modeling study done by Milstein Health Affairs. And really what it says is that the cost of health care over the long term, the red line on the bottom is if you just cover people. So that's part of their formula. Let's just get everybody covered. The next line, the green line is, well, the blue line is if you cover people and ensure that they get the best care. So again, get everybody covered is the first step. Next step is covered but plus best care. And the third one, the green line, the one with the lowest costs, are coverage plus care plus protection. So that's why that's where public health comes in. And that's the protection or the prevention, as we call it. Same thing with deaths. The red line is just covering people. The blue line is coverage plus care, and the green line is coverage plus care plus protection. So in the end, I think public health is an essential part of any health reform, and there's an advantage in Vermont that if we now have a single-payer healthcare system, it now comes out of a taxpayer finance mechanism, then it's in our best interest in Vermont to ensure that we have the protective and preventive things that we need to ensure people's health, to ensure a more productive population, and ultimately to lower our healthcare costs. So that's the journey we're on. I've been at this for about 2.5 years. I would say that when we started out, we were all certainly optimistic, but daunted by the task ahead of us. We're making progress. People are starting to talk in a different way, whether they be doctors, whether they be Vermonters, whether they be hospital administrators. And certainly I'm optimistic we've got a long way to go. And Dr. Hester is actually going to talk a little bit about the financing, which is the really tough nut that we have to crack looking forward. So thank you very much.